Okay. Hello everyone. Today my topic of discussion trauma series chest and abdominal injuries. First, I want to discuss three case scenarios. In first case, a 40 years male of no comorbids had stab injury with sharp knife of entry wound from left anterior chest, collapsed during CT scan, had brief CPR, got intubated, and right ICD placement was done. You have right a massive chemotherapy. I had received multiple blood products and shifted to our unit for further management. In second case, we had a 65 years female of known diabetic, hypertensive, rheumatoid arthritis, came with alleged history of RTA 5 days ago, skid and fall, sustained injuries like mild CPA, multiple rib fractures, had ICD in situ for left hemopneumothorax. She had grade 2 liver laceration and clinic contusion. She was shifted to our unit for further management. And in third case, we had a 34 years male of no comorbids had met with RTA hit by a four-wheeler, sustained left arm degloving injury with multiple rib fractures with flail segment. And he had underwent left arm complete disarticulation with multiple rib fractures, fixations. He had prolonged ICU stay, but finally we have able to get him discharged. Introduction of chest trauma. Damage to any vital organ leads to life threat. Physiological consequence of chest trauma: hypoxia, hypercarbia, and acidosis. Chest injuries result in significant number of deaths each year. 1 in every 4 cases of trauma death caused by chest injury. Thoracic injuries account for approximately 25% of all trauma-related deaths. Immediate deaths usually involve disruption of a heart or great vessel injury. Death within few hours, frequently caused by airway obstruction, tension pneumothorax, and cardiac tamponade. Pulmonary complications, sepsis, and missed injuries account for late death. Although thoracic injuries are life-threatening, most patients with thoracic injuries are managed conservatively. Only 10 to 15% of patients with chest trauma will require thoracotomy or sternotomy. Into types of chest injury: blunt, penetrating, crush, or compression. Blunt is usually closed injury, like in RTA, fall associated with multiple injuries like head, limb, and abdomen. And penetrating, it is open injury, mostly by assault like stabbing or gunshot, etc. Usually associated with chest wall damage, open pneumothorax, and organ injuries. Coming to blunt chest injury, mechanism is due to blunt force to the chest. Motor vehicle collision, the most common cause of major traumatic thoracic injury. High speed collision, seat belt non-use, extensive vehicular damage, steering wheel deformity, and fall from height. Multiple vital structures are at risk due to blunt chest injury. Major concern is chest wall injury, rib fractures, and flared chest. In cardiovascular injuries, blunt aortic injury and cardiac contusion. In pulmonary injuries, pneumothorax, contusions, and lacerations. Blunt aortic injury is the most lethal injury of thorax. In come to penetrating injury, mechanism due to projectile that enters chest causing small or large hole. Immediate results can be severe bleeding and impaired breathing. Any chest wound can involve underlying organ injury. Organs injured are usually those lie along the path of penetrating objects. This is caused by gunshot, stab wounds, and shrapnel wounds. Never to remove penetrating objects from the wound. All trauma patients must be managed in accordance with ATLS, which was discussed in previous lecture. I'm not going to detail. Initial assessment: immediate life-threatening injuries associated with thoracic injuries must be identified and addressed in primary survey by carefully assessing the patient's ABCD. During primary survey, airway problems include airway obstruction, tracheobronchial injury, in breathing problems, tension pneumothorax, open pneumothorax, flared chest, and pulmonary contusion. In circulatory problems, massive hemothorax, cardiac tamponade, and traumatic cardiac arrest. During secondary survey, potential life-threatening chest injuries, injuries that left untreated would likely result in death if not addressed and allowing several hours to establish diagnosis and initiate appropriate treatment. These are simple pneumothorax, pulmonary contusion, hemothorax, flail chest, blunt cardiac injury, traumatic aortic rupture, blunt esophageal rupture, traumatic diaphragmatic injury. Coming to airway obstruction, results from swelling, bleeding, or vomitus that aspirated into airway interface with gas exway. Look for evidence of air hunger, such as intercostal, supraclavicular retraction. Inspection oropharynx for foreign body obstruction. Listen for air movement at the patient nose, mouth, and lung field. Listen for any evidence of stridor. Patient with airway obstruction treat with clearance of blood vomitus from airway by suction or placing definitive airway as necessary. Coming to tracheobronchial injury, injury to trachea and major bronchus is unusual but potentially fatal condition. Majority of tracheobronchial injuries occur within 1 inch of carina. These injuries can be severe and majority patients die at the scene. Those who reach the hospital alive have high mortality rate because with associated injuries, inadequate airway, and or development of tension pneumothorax or tension pneumopericardium. Patient typically present with hemoptysis, cervical subcutaneous emphysema, tension pneumothorax, and cyanosis. Incomplete expansion of lung and continued large air leak in spite of after placing a chest tube suggests a tracheobronchial injury. Bronchoscopy is confirmative diagnosis. Immediate treatment includes placement of definitive airway using advanced airway techniques like fiber optic assisted ET tube placement by bypassing tear side. Later, immediate surgical intervention may be required. Coming to tension pneumothorax, it occurs when a one-way valve air leak occurs from lung or through the chest wall. Most common cause of tension pneumothorax, penetrating injury to the chest, blunt trauma with parenchymal injury, mechanical positive pressure ventilation with visceral pleural injury. Mechanism include air forced into pleural space with no means of escape, eventually collapsing the affected lung. Mediastinum is displaced to the opposite side, decreasing venous return and compressing the opposite lung. This results decrease in venous return, causing significant reduction in cardiac output. Tension pneumothorax is clinical diagnosis reflecting air under pressure in affected pleural space. Do not delay in treating to obtain any radiological confirmation. Clinical findings include severe respiratory distress, hypotension, unilateral absence of breath sounds, hyperresonance to percussion over affected hemithorax, neck vein distension, and tracheal deviation. This picture showing tension pneumo in left side. If the tension pneumothorax has not been diagnosed on clinical findings, radiologic investigation consider initially chest X-ray followed by bedside lung ultrasound. Treatment includes immediate needle decompression by inserting a large over needle catheter in fifth intercostal space slightly anterior to mid-axillary line. This converts pneumo into a simple pneumothorax. Finger thoracostomy is an alternative approach, then followed by immediate tube thoracostomy to be done. Open pneumothorax, usually caused by impalement injury or destructive penetrating wound, secondary gunshot. Large opening defect in chest wall, more than 3 cm diameter, with equilibrium between intrathoracic and atmospheric occurs. Management includes intubate if patient is unstable or in any respiratory distress. Close the chest wall defect with sterile occlusive dressing tape on the 3 sides to act as a flutter type valve. Avoid securing the dressing on all the 4 sides in absence of chest tube, which can lead to pneumothorax. Perform tube thoracostomy on affected side, but avoid placing the tube near or through the traumatic wound. Perform urgent thoracotomy to evacuate blood clots and treat associated intrathoracic injuries. This just showing open pneumothorax where during inspiration and expiration air enter and move in and out. In tension pneumo, there is a valve and it acts as a valve wound, so air enters into the during inspiration and does not exhale to during expiration. Massive hemothorax, coming common in penetrating trauma with hilar or systemic vascular disruption. Intercostal and internal mammary vessels are most commonly injured. Each hemithorax can hold up to 3 liters of blood. Neck pains can be flat, secondary to hypovolemia or distended because of mechanical effects of intrathoracic blood. Hilar or great vessel disruption will present with severe shock. Diagnosed made as patient in hemorrhagic shock, unilateral absence or diminished of blood sounds, unilateral dullness to percussion, flat neck veins. X-ray show unilateral white outflow. The X-ray showing left massive hemothorax. Treatment include intubate if patient is in shock or in respiratory difficulty. Establish large bore IV access and have blood products available before decompression. If available, have an auto transfusion setup for the chest tube collection system. Perform tube thoracostomy with large tube catheter in fifth intercostal space. Indication for thoracotomy: hemorrhagic decompensation or ongoing instability because of chest bleed. More than 1500 ml blood evacuated initially, or ongoing bleed of more than 200 ml per hour for 4 hours. Failure to completely drain hemothorax despite at least 2 functional and appropriate positioned chest tubes. Consider early video assisted thoracoscopy for incompletely drained blood clots. Coming to flail chest, usually results from direct high energy impact. The flail segment classically involves anterior or lateral ribs. Posterior ribs are usually do not produce flail segment because of heavy musculature provides its stability. A diagnosis is made when 2 or more ribs are fractured in 2 or more locations, which often may lead to paradoxical motion of the chest wall. Patient on positive pressure ventilation may not show this paradoxical motion. Blunt force of injury typically produce underlying pulmonary contusion. Flail segment with underlying pulmonary contusion and splinting cause pain and exacerbate hypoxia. Associated abdominal injury occurs in approximately 15% of patients with flail chest. Management: immediately intubate patient for any signs of respiratory distress or shock. That includes labored breathing, respiratory more than 35, saturation less than 90, and PaO2 less than 60, or PCO2 going up to 55. Pain management includes regional analgesia in form of epidural block is most effective. System of opioids by continuous infusion, intercostal nerve block, and continuous positive pressure CPAP. And coming to cardiac tamponade, it is compression of heart by an accumulation of fluid in the pericardial space, results in penetrating or blunt chest trauma. Diagnosis: if patient is awake, he is extremely anxious and reluctant to lay flat. Suspect tamponade in those with persistent hypotension, acidosis, base deficit despite adequate blood and fluid resistance. Classical signs include Beck's triad, jugular venous distension, and hypotension, muffled heart sound. Pulses paradoxical. Decrease in systolic pressure of more than 10 mm during inspiration. Kussmaul sign, which rise in venous pressure with inspiration when breathing spontaneously. EFAST and echocardiography examination should be performed to identify pericardial fluid. Positive pericardial view on fast in unstable patient should be taken up for immediate thoracotomy or sternotomy. If surgical intervention not possible, pericardiocentesis can be therapeutic, but it is not a definitive treatment. Subxiphoid pericardiocentesis is used as temporary maneuver by using Seldinger technique. Coming to blunt aortic injury, majority of patients with major aortic injury dies immediately second to aortic transection. Aortic tear usually occurs from high energy injuries to the thorax and rapid deceleration. There is no clinical signs or examination finding with sufficient sensitivity and specificity to detect or rule out blunt aortic injury. High energy trauma, rapid deceleration, chest wall contusion with deformity should raise suspicious of blunt aortic injury. Isolated mediastinal injury should raise suspicious of involving aortic injury. Clinical signs are asymmetry in upper extremity blood pressure and upper extremity hypertension, widened pulse pressure, chest wall contusion, posterior pain, and interscapular murmur. Radiological signs include in chest X-ray, widened mediastinum is most consistent finding, obliterating of aortic notch, uh, deviation of trachea to right, depression of left main bronchus, elevation and rightward shift of a right mainstem bronchus, deviation of esophagus or NG tube to right, widened paratracheal strip and paraspinal interface, left hemothorax, first and second rib scapula and sternal fracture. False positive and false negative findings can occur. Aortography was the gold standard for diagnosis. Chest computed tomography recently become more valuable diagnostic tool for aortic injury. Helical and high-speed, high resonance scans can provide diagnosis of aortic injury. Transesophageal echocardiography may not be reliable as angiogram, but positive TE will confirm the location of injury in expert management. Coming to management, close monitoring of blood pressure and heart rates to slow the expansion of injury. Goal of systolic blood pressure should be up to 100 millimeter mercury and heartbeats less than 100 beats per minute. Beta blockers should be administered only after significant hemorrhage from other injuries have been ruled out. Ismolol is short acting, dose 500 microgram per kg, loading dose followed by 50 micrograms per kg as continuous infusion. Labetalol, long acting beta or alpha blocker, dose is 20 mg, bolus followed by 0.2 to 2 mg per kg per hour infusion. Severe techniques are available for definitive repair. Endovascular aortic stent grafts are now available. Coming to blunt cardiac injury, spectrum of injury to the heart can range from asymptomatic cardiac muscle contusion to clinical significant dysarthria, acute heart failure, valvular injury, and or cardiac rupture. Most common complications, dysarthria such as sinus tachy, premature atrial contraction, atrial fibrillation, premature ventricular contraction. Other changes may be RBBP and ST elevation, T wave flattening. Diagnosis made by 12 lead ECG, echocardiography to assess valve motion, valvular competence, cardiac troponin I levels. Management include dysarthria treatment as necessary according to ACLS protocol. Patients with ECG changes and elevated cardiac enzymes treated similar to those of myocardial infarction. Pulmonary contusion, most common potentially lethal chest injury caused by hemorrhage into lung parenchyma, commonly accompanied with flail segment and multiple rib fractures. Natural process is worsening hypoxemia for first 24 to 48 hours. Diagnosis, chest X-ray finding typically delayed in appearance and non-segment. Hemoptysis and blood in ET tube, signs of pulmonary contusion. CT scan is more sensitive test for pulmonary contusion. Treatment include supplying high flow oxygen, supplemental oxygen, analgesia, supportive ventilation if needed with mechanical ventilator. These are the scoring. Pulmonary contusion score based on plain chest X-ray at the time of admission after 24 hours after trauma. It is classified as mild, moderate, severe. In how we calculate, divide the lung fields into upper, middle, and lower third, assigning a score of 1 to 3 into each region on the based amount of radiological parenchymal changes. A mild contusion if PCA score is 1 to 2, moderate contusion if 3 to 9, and severe if PCA score is 10 to 18. CT dependent Wagner score. Wagner and Janssen developed a chest trauma score based on CT scan, classified according to volume of pulmonary contusion, pulmonary lesion. This described as grade 1, more than 28% involvement, patient may require mechanical ventilator support. And grade 2, 90 to 27%, 60% of patients may require mechanical ventilator. Grade 3, less than 19%, patient may not require ventilator support. This is thoracic trauma severity score. It is CT independent scoring system that is based on combination of 5 anatomical and physiological parameters at the time of admission. Extent of pulmonary contusion, number of rib fractures, pulmonary lesion, age, and PF ratios. It predicts post-traumatic complications and outcomes. Each parameter is assigned a value of 0 to 5. A TTS score ranges from 0 to 25. Based on PF ratio, if more than 400, 0 300 to 400, 1, 200, 300, 2, 150 to 200, 3, and 150, more less than 150, this points will be 5. Come to esophageal injury. Most injuries result from penetrating trauma. Blunt esophageal injury is rare. Presentation varies according to site of injury. Cervical, subcutaneous emphysema, and hematemesis can be seen. Thoracic trauma, mediastinal emphysema, subcutaneous emphysema, and pleural effusion. Retroesophageal air, unexplained fever within 24 hours of injury. Intra-abdominal symptoms asymptomatical initially, but may have pneumoperitoneum and chemoperitoneum. Diagnosis made by penetrating trajectories involving mediastinum or neck mandatory diagnostic workup to exclude injuries to the esophagus. Many penetrating injuries are detected at the time of emergency thoracotomy or laparotomy. Esophagoscopy and esophagogram are used with equal sensitivity to detect esophageal injury. CT scan have role in determining trajectory in the stable patient. Management includes definitive repair if injury is less than 6 years old, close primarily in 2 layers with observable suture and cover with pleura and intercostal muscle flap. Complete injury, complex injury less than more than 12 years old, 12 hours old, diverting cervical esophagostomy and overswing of distal esophagus should be considered with signs of mediastinum. The topic abdominal trauma. Introduction. Abdominal trauma divided into penetrating abdominal trauma and blunt abdominal trauma. Penetrating abdominal trauma usually diagnosed based on clinical signs. Blunt abdominal trauma more likely to be delayed or altogether missed because of clinical signs are less obvious. Blunt abdominal trauma, greater mortality than penetrating trauma because more difficult to diagnose. Motor vehicle crash account for 70% of blunt abdominal injuries, include fall, motorcycle or bicycle crash, sporting mishap, and assault. Direct blow can cause compression crushing injury to abdomen, pelvic viscera. In patients with abdominal trauma, organ most frequently injured are spleen, 40 to 55%, liver 35 to 45%, and small bowel 5 to 10%. Pathophysiology include rupture or burst injury of hollow organ by sudden rise in intra-abdominal pressure, crushing effect, acceleration and deceleration force causes shear injury. Seat belt injury highly correlated with intraperitoneal injury. To penetrating abdominal trauma, stab wounds and low energy gunshot wounds causes tissue damage by laceration and tearing. Stab wounds more common than firearm wounds. Gunshot wounds causes 90% of death. Most commonly injured are small intestine, colon, and liver. Diagnostic and treatment priorities include first, recognize presence of shock or intra-abdominal bleed. Second, start resuscitative measures for shock and bleeding. Third, determine if abdomen is the source for shock or bleeding. Fourth, determine if emergency laparotomy is needed. Fifth, complete secondary survey, abdominal radiographic studies to determine if occult abdominal injury is present, and conduct frequent reassessment. Secondary surveillance history for all trauma patients is not necessary to take accurate to make accurate diagnosis. Symptoms include pain, vomiting, hematuria, hematochezia, dyspnea, and respiratory distress, allergies, medications, last meal, and events mechanism of injury. Come to physical examination by inspection, abrasions, contusion, laceration, deformity, entrance and exit wound to determine path of injury. Greaterness coming to palpation, ellipse, superficial, deep, and rebounding tenderness and involving muscle guarding. Percussion, subtle signs of peritonitis, tympani in gastric dilatation or free air, dullness with hemoperitoneum, and auscultation, bowel sounds may be decreased. Greaterness sign is blue discoloration of lower flank, lower back associated with retroperitoneal bleed of pancreas, kidney or pelvic fracture. Colon sign, bluish discoloration around umbilicus indicate peritoneal bleed, often pancreatic hemorrhage. Chest sign, shoulder pain while supine caused by diaphragmatic irritation, seen in splenic injury, free air, intra-abdominal bleeding. Balance sign, dull percussion in lower upper quadrant, signs of splenic injury, blood accumulation subcapsular or extracapsular spleen. Imaging in abdominal trauma. In chest X-ray, look for any pneumothorax, hemothorax, raised left or right hemidiaphragm, suspect perisplenic or hepatic hematoma, lower lip fractures may lead to liver and splenic injuries, abdominal contents in the chest by ruptured hemidiaphragm. In abdominal X-ray, look for pneumoperitoneum. Is there any perforation of hollow viscus? Ground glass appearance suggestive of massive hemoperitoneum. Dilated gut loops suggest retroperitoneal hematoma or injury. Double wall sign, air inside or outside the bowel. Medial displacement of stomach such as splenic hematoma. Obliterating of psoas shadow is retroperitoneal bleed. Pelvic bone fractures, high suspicion of bladder or urethra or rectal injury. Fast in trauma to diagnose free peritoneal fluid, evaluate solid organ hematoma, which include 4 areas: pericardium, perihepatic and hepatorenal space, perisplenic, and pelvis. Sensitivity is 60 to 95% for detecting at least 100 to 500 ml fluid. EFAST is adding thoracic windows to look for pneumothorax. Sensitivity is 59 to and specificity is up to 99%. CT imaging accurate for solid visceral lesion and intraperitoneal hemorrhage. Guide non-operative management of damage. IV contrast is recommended. Disadvantage is insensitive for injuries of pancreas, diaphragm, and small bowel and mesentery. This is a comparison between diagnostic peritoneal lavage, FAST, and CT scan, where diagnostic peritoneal lavage has no significance in recent days when FAST and CT scan playing major role. Exploratory laboratory. Potential indications include hemodynamic instability, evidence of peritonitis to achieve control of hemorrhage and control of spillage, traumatic diaphragmatic injury with herniation, severe solid organ injury, infarction due to post-traumatic occlusion of the blood supply, mesenteric tear, unexplained moderate to large amount of free fluid, and failed non-operative management. Coming to specific organ trauma, splenic injury, severity of splenic injury can be described with grading system according to American Association Surgeon of Trauma. Grade 1 with laceration less than 1 centimeter and subscapular hematoma of less than 10% of surface area. Grade 2 laceration of 1 to 3 centimeters and subscapular hematoma of 10 to 50% of surface area. And grade 3 laceration more than 3 centimeters and subscapular hematoma of more than 50%. And grade 4 if there is segmental or hilar vascular injury and devascularization of more than 25% of spleen. In grade 5, shattered spleen with hilar injury. Management generally splenic injuries managed conservatively. However, in presence of multiple injuries and critical instability, surgery is opted. Splenectomy and partial splenectomy in grade 4 to 5 injuries may require anatomical resection, including ligation of lobar artery. Splenography in grade 2 and grade 3, suture repair or mesh wrap of capsular defect, parenchyma saving operation of the spleen. Post-operative care, risk of recurrent bleeding in any missed vascular structure or inadequate ligated vessels. Immunization against pneumococcus species within 24 to 2 weeks. Anticoagulation for risk of DVT. Opportunistic post-splenectomy infection should be addressed. Coming to liver injury, commonly injured in abdominal trauma can have significant blood loss. Right lobe more frequently injured. 6th, 7th, 8th segments commonly involved. CT grading of liver trauma. Grade 1 is laceration less than 1 centimeter depth with subscapular hematoma involving less than 10% of surface area. Grade 2 with laceration 1 to 3 centimeters depth and intraparenchymal hematoma with less than 10 centimeters diameter and surface area of hematoma 10 to 50%. Grade 3 with laceration of more than 3 centimeters depth and intraparenchymal hematoma of more than 10 centimeters diameter and with subscapular hematoma of more than 50% of surface area. Grade 4 parenchymal disruption with 25 to 75% and active bleeding extending into peritoneum. And grade 5 parenchymal disruption with hepatic venous injury. Management, maximum non-operative management of liver injury. Coming to management according to grading, grade 1 and grade 2 are minor injuries require minimal repair of conservative. Grade 3 and grade 3 to grade 5 severe may require surgical intervention. Indication for surgical management, hemodynamic instability or transfusion more than 2 blood volumes or 40 ml per kg, devitalized parenchyma, sepsis, biloma, exploratory laparotomy in any penetrating trauma is considered. Coming to renal trauma, 65% of all renal injuries due to direct blow. Grading of renal trauma by grade 1 is no laceration but subscapular hematoma. In grade 2, laceration less than 1 centimeter depth with perirenal hematoma and perinephric fascia. Grade 3 is laceration more than 1 centimeter depth with segmental vein or artery injury and segmental complete infarction due to vessel thrombosis without active bleeding. Grade 5, main artery or vein or hilar avulsion. Management, 90% blunt renal injuries are managed non-operatively. Minor grade 1 to grade 2 injuries are properly treated by observation. Renovascular injury and destructive parenchymal injury with hypotension require operative management. For destructive parenchyma and irreparable renovascular injuries, nephrectomy may be the only option. These are unidentified and missed injuries. Haloviscous injury. Duodenum is most commonly injured and small bowel injured at a relatively fixed area, duodenogastro-jejunal flexure and ileocecal junction by shear force. Colon relatively protected. Gaseous distension of cecum, most vulnerable part as stomach rarely injured by compression caused esophago-gastro junction bursting. Coming retroperitoneal urogenital tract, parenchymal injury, 4% case of trauma results from direct blow in epigastric region. Bladder, most commonly injured extraperitoneally by shear force at vesico-urethral junction and intraperitoneally by blunt force on distended bladder. Rupture to prostatic urethra by shear force is commonly seen with hemorrhage. Coming to our case scenarios, in first case, we had right internal mammary artery injury, which was corrected immediately by surgical repair. Later, patient got stabilized and improved. In second case, we had a delayed pseudoendomesenal bleed from splenic artery after 10 days of ICU stay, which he underwent coil embolization. Patient did not survive later in view of prolonged ICU stay and difficult wean of ventilator support. In case 3, patient had a left upper limb injury for which he underwent surgery and multiple debridements for wound, difficult weaning from the ventilator, severe catabolic state secondary to severe traumatic injury. He had prolonged ICU stay. And to summarize, trauma to chest has worsened due to increased number of accidents and violence. Essential life-threatening thoracic injury must be identified in primary survey. Ideal management should be multidisciplinary. Early diagnosis and aggressive management is the key to decrease morbidity and mortality. Thoracic traumatic score more than 7 points increase morbidity. If more than 20 points predict fatal prognosis and prolonged mechanical ventilator support. Majority of thoracic injuries are managed conservatively. Traumatic abdominal injuries can be missed. High index of suspicion must be in all trauma patients. A mechanism of injury should guide your investigation. Diagnostic adjustments have limitation with respect to different organ injuries. Fast scan in hemonically unstable patients, rapid assessment for intra-abdominal bleed. CT scan lack sensitivity in hollow viscous injuries. In injury to diaphragm and pancreas bladder commonly missed in blunt abdominal injury. Traumatic patients do not die because of definitive surgical repair, but from the lethal triad of acidosis, coagulopathy, hypothermia that developed while lengthy procedures. Thank you.
Thank you, Shiva. Kishore, you want to add anything?
Nothing, sir. I think it's almost covered exhaustively. He has covered the entire topic. No comments, sir.
So, when you look at chest trauma, few points you need to remember. The mechanism of injury, as with all other aspects of trauma, the mechanism of injury is also very important. The most important thing to note is the seatbelt injuries. For the passenger and the driver, the pattern of seatbelt injuries are a little different. So, to look at in India where the right side drive cars are available, the left side, the passenger sits on the left side, so the seatbelt starts from the left and goes to the right. So you can expect injuries of the left clavicle, the aorta, the duodenal flexure, and the liver. Whereas for the driver, it is the opposite. So the mechanism of injury, whether it was a restrained passenger or unrestrained passenger, makes a lot of difference. The easiest clue that there is a thoracic vascular injury, although it is a mediastinal widening and apical pleural gap, all these are known signs of traumatic pneumothorax. The most reliable sign of an aortic injury after chest trauma is a deviation of the nasogastric tube to the right of the midline. If the patient has had a nasogastric tube inserted on during the transport, this is the most sensitive sign of suggestion of aortic injury. Any traumatic chest injury patient who has a clavicular fracture, first and second rib fracture, or external fracture should have a angiogram of the chest to rule out vascular injury. These vascular injuries may not always be related to aorta, but they can also be associated with subclavian injuries and thoracic duct injuries. So it's always imperative that these injuries should be addressed. Certain injuries usually kill the patient on the side, and those injuries include disruption of the aorta, tracheobronchial disruption. Those are catastrophic injuries. But the injuries which kill the patient in the emergency room are a sucking open pneumothorax, which is an emergency. Another injury which sometimes gets overlooked in the primary survey and secondary survey is cardiac injury, because the cardiac injury does not manifest until after 48 to 72 hours. So any patient who has multiple ectopics or who has had a non-thoracic trauma with confusion of the third, fourth, fifth intercostal spaces or epigastrium needs to have a troponin done at least once a day for the first 4 days to identify whether there has been cardiac. So thoracic trauma is a tricky ball game, and abdominal trauma, I think Shiva has covered the exhaustive. Next week, we will look at traumatic brain injury that will be dealt with by Dr. Chandresh and will be guided by Dr. Ghanshyam. Till then,